The SARS coronavirus is an epidemic that quickly infects world populations through contact with human droplets or surfaces that are contaminated by affected individuals. First transmitted from civet cats and raccoon dogs sold live for food at Guangdong markets, SARS spread from China in 2003 via animals to humans, resulting in widespread illness and death. Manifestations of SARS include flu-like symptoms such as fever, malaise, sore throat, and a dry, non-productive cough. SARS can progress rapidly to pneumonia, resulting in acute respiratory distress. Beginning in November 2002, SARS began in urbanized areas of Guangdong, South China, spreading globally through domestic and international air travel to Australia, Canada, China, Taiwan, Indonesia, Malaysia, New Zealand, the Philippines, Korea, Singapore, Thailand, and Vietnam by August 2003. Without realizing the seriousness of the situation, the SARS epidemic spread even more. In February 2003, an infected medical doctor from Guangdong brought SARS into Hong Kong, spreading the illness to visitors and guests at Hotel M. The doctor was then admitted to the Prince of Wales Hospital, infecting 138 hospital staff and visitors by March 2003. Hotel M guests infected with SARS later traveled to various countries including Vietnam, Singapore, and Canada, where further outbreaks occurred. The WHO responded by issuing a global warning, ultimately declaring SARS a worldwide threat, and by July 2003, the WHO declared that the SARS transmission chain between humans had been broken. Although persons of all ages are susceptible to SARS, the SARS outbreak had the highest case fatality ratio in persons over 64. Additional groups affected by the SARS virus included those living in urban areas, patients and visitors within the care facilities of hospitalized cases, and those within the households in contact with infected SARS victims. Most alarmingly, the proportion of affected healthcare workers accounted for nearly 1/5 of all cases within Canada and Singapore. The person-place-time model is used by epidemiologists to investigate the disease pattern in a community. There were a total of 8,098 cases of SARS and 774 deaths worldwide between November 2002 and August 2003. The mortality and morbidity rates show that even though the SARS virus originated in Guangdong, it was not the area where the most cases or deaths occurred. Hong Kong was the country that had the largest crude death rate and prevalence rate due to their condensed population.
Long-term consequences from the SARS epidemic have impacted local communities as well as countries worldwide, with a global cost estimated at $40 billion. Specifically, China had experienced gaps in communication, contributing to delays in the reporting of the virus. China has since improved their case reporting structure and emergency response system. In addition, nurses and doctors working in hospitals who came in contact with infected patients often became infected with the SARS virus themselves, later suffering from debilitating psychological effects. Because of these high incidences of infection in hospitalized areas, hand washing practices and personal protective equipment use were eventually increased in several hospitals around the country. New policies were implemented in response to the SARS epidemic of 2003. The Do Not Board policy of 2007 listed names of persons most likely to travel via airplane while posing as infectious threats. Another policy increased the number of quarantine stations around the country from 8 to 20. In addition, the CDC established the Community Interventions for Infection Control Unit to prevent the spread of infectious disease. This infection control effort emphasized research and education involving non-pharmacological interventions. Many studies pertaining to the epidemiology of SARS have been completed exploring the risk of a re-emerging epidemic. In a study by Jefferson and al., results indicated that the spread of the virus were successfully prevented by hand washing and implementing barrier isolation measures. Another study by Saeed et al. Emphasized the need for clarification during pandemic planning. After serious outbreaks occurred in 2003, the World Health Organization, with the help of other public health officials, assessed the effectiveness of interventions to prevent the transmission of SARS across international borders. Many individuals residing in affected areas chose to wear masks outside their homes. Many local communities also closed their public facilities while requiring masks for all persons at public transportation services, restaurants, and hospitals. People in affected areas were advised to measure their temperature daily, call into fever hotlines, and participate in evaluation clinics. These measures were applied along with providing health information to international travelers, isolating specific cases, and recognizing potential outbreaks in a timelier manner. With the establishment of these interventions, public health officials helped minimize the chance of global reinfection with SARS.